Good afternoon. So it's 5 minutes left till the poster session. But as I want to make most use of the time for an interactive discussion, so would like to start giving some information how we will do it. Because we have 5 people with us who benefited from this small grant scheme we were discussing. We have Francisca Meyanti from Indonesia and Kanika Korala from Nepal. Both have been introducing themselves this morning. They are working within the NIDIAC project, this large consortium that actually investigates a better approach to diagnosis of neglected infectious diseases. A patient-centered approach, let's say. So how can we work out the diagnosis in a real-life patient? Not a kind of theoretical person suspect of Kala-Azar, but a true patient that comes with fever, because there is a lot in the differential diagnosis. So same for people coming with complaints of digestive nature or whatever. What is this? Is there a relation with Helminth disease? So, well, they will explain the project and their work, and the poster is over there. So, Kanika is a medical doctor. She is a candidate for a PhD track, and she works as a research coordinator in Dharan in BP Korala Institute of Health Sciences, yes. That is the institute where Professor Suman Rijal is the focal person for our network, okay? So that's Kanika. Francisca works, but she can explain, but you sent me the biosketch. She works, she's also an epidemiologist. She works in Indonesia, in Gadjah Mada University. Now, Dr. Yodi Mahendra Datta, the focal person from Gadjah Mada, is not here. He's in Germany. And did you get some news from him? Is he coming? Or? No, he's not. He has another commitment in Germany. Yes, it was not possible for him to join us. So, but Francisca and Kanika are working together, and they will, in a few minutes, they will tell you much more about their work. So that is one poster. Another one is a poster that was brought to us from Zambia by Dr. Chitwambi Makungu. He's a PhD student, you can see it. Now, we had a little logistical problem because the story was, and Chitwambi told me that the poster was actually on the rooftop of the car on his way to the airport. And so it was there when he left his home, but when he arrived in the airport, that was gone. So somewhere on the road, the poster has been, anyway, volatilisé. They say in French, it disappeared. So we tried to print it in Bangalore, and that's perfectly possible, but due to the huge traffic jams, this poster is still on its way, and that's why it's now projected for you. So that's here. Chitwambi is a veterinary scientist, and he will tell a lot more about his work on, it's about an innovative project on health education for hygiene in a community-based. So I let him explain that. That's 2. Then we have one from my friend Narayan Bhattarai. Where is he? Over there. Narayan Bhattarai is a postdoc scientist, now assistant professor. Congratulations. He is in the same institute in Nepal, where Suman is working. And Narayan, you know him, he is also heading the molecular biology unit in that institute. Actually, that's a result of capacity building that is going on the coordination of Suman in that institute. So, and Narayan will explain some of his work in that laboratory, okay? That's, and then we have number 4, where is it? And now I look around, who is the 4th poster? Yes, Mark from Peru, Braulio, Mark from Peru, and you are presenting something, yes, you are belonging to the Caetano Heredia University, Institute von Humboldt. And he did work, he explained he's involved in clinical research on cutaneous leishmaniasis since a long time, medical doctor, yes. And he already benefited from several small grant schemes. Not only this one, but there were other ones, the TDR one and ICIT, I read in your... So, and he makes very good use of this type of funding. And so he will explain you some of his work on the cutaneous leash. So it's not for me to talk about these posters. It's for my role to explain you how we set it up. So they each have prepared a short presentation, but we would like, usually poster sessions in congresses are very boring. Nobody attends posters. Here we ask all of you, please, could you join us for a 1 hour very interactive session? I would like each of you, you have heard the four, please start with the one of your choice. And so you see them. This is Chitwambu. Narayan is in the back, the Nidiag is there, and Borlios is over there. So please, could you go and stand next to your posters, the presenters, and then it's more visible where they are. So the people sitting, choosing for Chitwambu's poster, we will put chairs so that you can sit. So the idea is that you split. We will start the timing. After exactly 15 minutes, you will be asked to rotate to the next one in a clockwise fashion. So very simple. Okay? If you're really, really interested, of course you can stay a bit longer on the same one. I will not be policing and what you do, but the idea is that you really try to see each of them. So they will explain it briefly, and then please ask all your questions, give your suggestions in these small groups. Okay? Is that clear? Anything you would like? More information at this point? So we only have an hour, so I would, make your choice, join them, they're waiting for you, and we can start the timer, actually. Yes. So, it is, please, don't waste this precious time. They are waiting for you, these junior scientists.
Encouraging sustainability, because previous programs usually give money or other subsidies, and usually when those programs run out, the situation goes back to the way it was. So this is a very unique approach. And what we're doing, since it targets sanitation, we're trying to see whether it can help us as an integrated method of controlling cysticercosis, which, as you know, is very strongly linked to sanitation and also soil transgenic. And they keep a lot of pigs free range. So in that environment, cysticercosis and as well as soil transmitted rabies thrive. So what we're doing in the small segment that was funded by SNMPZ is to look at the baseline prevalence of sanitation and look at the progress on after triggering CLTS, the progress of sanitation construction, as well as to look at the determinants that are prevailing in terms of commencing ownership of land-rated households. The intention is to try to integrate this into future implementation program as when it's rolled out in order to maximize the impact that it has on public health. So our results here basically are in three parts. What we found in our study area, which involved 526 individuals.
Use a combined composed reference diagnosis. We compare the PCR and brush against two positive results, which can be PCR in invasive samples, that is commonly used, and scrapping and leishman skin test. Okay? So health workers send us the samples, and we compare the sensitivities or approach against the traditional procedures. Okay? So 79 individuals were enrolled during this period.
White mosquito, and then we would have to understand that means dengue.
She's the dengue.
Yeah, and now we have lots of foci in the park, and we have dengue outbreaks. And we have had many students, even in BPKHS, having dengue now. So Barat is one of the Mumbai where dengue is now seen in Mumbai. And so when we asked how do we know about these illnesses, they said because we have had experience with our family members who have suffered from such illnesses, or we have heard from the neighbors who have had such illnesses in the past. And then we came to the treatment seeking. And for the treatment seeking, we asked them where would be the first place you would go to if you would have a febrile illness. They said they would go to a medical shop and they would take simple medicines, over-the-counter medicines, and ask further that what are the over-the-counter medicines, simple medicines that you can take. So they would say that they would take a paracetamol, and most of them would actually go to a tertiary or a higher center only if the fever would not subside. After taking multiple medicines from the medical shop, and if the fever would not subside, only then they would consider going to a higher center.
Yes, it's true. These tests are not developed for the animals, for humans. Maybe I think we have to get this test and science.
Because I don't know the antibodies might not be compatible with the monoclonals that are used in the test kit, and especially the sensitivity. Even if they match, then the sensitivity might vary a lot between different carrier animal species. So in the end, it might have a very low sensitivity, and still there might be a lot of infected cattle or buffalo, but you would not be able to detect it. So that is always an important point to keep in mind.
Apply the antibody test.
A test for one species or another one.
Maybe you have a track. So the previous study infections. They have a parasite.
Passing by.
They are passing by. So they have a.
इसका बस ट्रेड बटर सर ओके
all the infections that never disease.
That's the point. It can be how long whether they are able to get rid of it.
Or they just parasite at certain point of time.
Diagnosis to have a more clear diagnosis.
How do you explain those false positives?
Since this study was performed in two places, in Peru and Bolivia, we are analyzing the data, but Bolivia didn't use as a routine the KDNA PCR for diagnosis. They used another procedure, the HLS PCR. So I think that can be a reason. They are starting to use the right procedure. So that's one possibility.
Most of these patients, they use this is actually something that's cultural. The fact is, we found very few of patients came to this health center used jump gas mask. But from the healthcare provider said they mentioned many of them were covered by this jump gas mask or national health insurance policy. So when another one is just for transportation, which is very
Implemented is a process which is called triggering. Basically, it's a facilitation process which shows them how bad authentication is, and how basically they are eating their own feces by scrubbing. So it's quite of like a very interesting methodology the way it's done. And after that is done, you see that they really see.
Villages from Bolivia, those we went to these villages so
Yes, 6, 5, 4, 3, 2, 1. Yes, we did it. Thank you very much. And I know, yes, this was intense. very tiring for everybody. But thank you that you participated in this. To bring the posters also to the general poster session, so that they will still be on display in the colloquium, so that other people can also have a look at them, for the people to participate in the poster session over there. We'll put them in a corner. Okay, thank you. So as this session stops, it's my pleasure to hand over this microphone to David Hendricks. Where is he? Ah, okay. So here, David.
A little bit this morning, or it was raised several times, this One Health concept. It was raised a couple of times this morning. So what we want to do in this session is to go a little bit more in depth and try to explore a little bit more how the network in the future can maybe address or better address the One Health concept, or the strategies that exist within this concept, and how we can implement them in activities of the network. So that's kind of the idea, what we want to do with this session. Now, there's two speakers here in the room. We've got Tanguy Marcotti. I'd just like to ask them to come up and take a seat, because afterwards we'll be taking questions, and it'll be easier if you're sitting there. And then Manish Kakar. Manish, there we are. Sorry, I'm a little bit blinded by the lights. So Manish and Tanguy are experts when it comes to One Health. They each have a lot of experience in this context, and they're going to share some of their experiences with us before we start a more general discussion in this session. So I'll introduce each of them as we go on. They'll present for about 20 minutes each. We'll do a short Q&A after each of the presentations. Move on to the next presentation, and then we'll start an introduction for a larger group discussion in which we'll brainstorm a little bit about how can we implement these kind of strategies, ideas within our broader network. So without further ado, I will present the first speaker. So the first speaker is going to be Dr. Manish Kakar. He's a clinician, has an MPH. He's associate professor and senior infectious diseases specialist at the Public Health Foundation of India, where he has been working for 6 years and has been involved in furthering the Zoonoses agenda in India and South Asia through the Roadmap to Combat Zoonoses initiative, which he launched in 2008. He's also a steering committee member of various One Health initiatives or programs, such as the One Health Alliance of South Asia, and is also the co-director of the India Research Initiative on Urban Zoonoses. In addition, he also serves on various government committees and task forces on infectious diseases. So please, Dr. Kakar, may I ask you to present? So I think everything is there. Right. You should be able to use this to advance and go back. And it's also got a pointer.
This is the pointer, this red one.
Yeah.
Okay. Thanks, David. At the outset, I would like to thank the organizers for giving me this opportunity and to share our experiences working in the field of zoonoses and One Health with the audience and with this network. It will be a bit of a challenge to cover experiences, challenges in a huge country like India, and what are some of the options that are possible when it comes to taking forward the One Health agenda in about 20 minutes. But what I've done is I've basically taken the case of zoonoses research at Public Health Foundation of India. So how we started working in this area, how our work evolved over a period of time, how did we go about prioritizing our work. So basically sharing those experiences, what have been some of the positive experiences at the end of close to 4.5 years of work in this area, and what have been some not so positive experiences. So this is how I try to sort of sum up all these perspectives and share them with you. So What I'll do is I'll briefly set the context. I'll talk about the vulnerabilities and challenges and the national response to the issues of zoonosis and One Health in India, what has happened in the recent years. And then within that context, and given the status of Public Health Foundation of India as a public-private partnership, how did we move into this particular context? How did we start identifying a role for us? And that probably could be an experience which we could share with some of the organizations over here. And there could be some lessons which we could exchange around, the way we moved into the entire situation. And that could be one of the possible ways of, forging One Health collaborations and some of the low-hanging fruits which could be starting points to operationalize One Health in different contexts. So I'll be talking a bit about the PHFI response. The most I'll focus on would be the research, zoonosis-related research that we've done in the last 3.5–4 years, because that's also more relevant for this kind of a group. And then I'll very briefly in one slide I'll try to summarize some of the experiences, and then we can take questions and I can share more in-depth information on specific aspects. So in terms of India's vulnerabilities, challenges, and national response, this is like preaching to the converted. This is probably one of the most cited illustrations when it comes to emerging infectious diseases and zoonotic hotspots. So the Indian subcontinent has been identified as one of the 4 global hotspots at increased risk of emergence of new infections from all sources. And the recent evidence also points that when it comes to endemic zoonosis, it's again, India is one of the hotspots because there is a strong association between poverty, neglected zoonosis, and emerging livestock systems. And India is leading in all these 3 fronts. So it's actually on both 3 fronts. The vulnerability is pretty high. And one is not surprised that in the last couple of decades, almost every other year we've had a pathogen either emerging or re-emerging, or if introduced into a country like India, it has spread at an enormous pace. So there is definitely heightened vulnerability when it comes to zoonosis, and therefore need for One Health approaches. Now, apart from the typical eco-epidemiological challenges and drivers which drive this vulnerability, what really needs attention is the challenges in zoonosis control, and these are really the challenges which are systemic in nature. So this is not a very exhaustive list because the time was limited, but I'll just touch upon some of the important challenges that we have faced traditionally. And a number of countries present over here could actually identify with some of these challenges. So for example, when it comes to intersectoral coordination, and I'm using the term coordination, I'm not using the term collaboration because there is a world of difference between coordination and collaboration. So we're still not coordinating within each other, so collaboration is a far-fetched dream. So there is very limited intersectoral coordination, especially when you go to the subnational levels. I mean, the best case that we have seen so far is the coordination between different sectors following the avian influenza outbreaks. So this is what led to the joint task force. I'll show it in the subsequent slides. So there is a national task force between different sectors. There is a joint monitoring group, which is more of an implementation framework, a coordinated implementation framework. But when it comes to the subnational level, we really don't have anything apart from H5N1. And the states which have not been hit by H5N1 outbreaks, there even the subnational coordination mechanisms have kind of fizzled out over a period of time. So unless you are hit by an emergency, you don't really come together. So that's been a typical phenomenon. But beyond H5N1, the coordination has been extremely limited. There are very few examples from some of the more progressive states like Gujarat and Tamil Nadu who have had some intersectoral coordination mechanisms for other zoonoses, but nothing beyond H5N1 in most of the states. The other problem with zoonosis is that there is no program, dedicated program focus. So if it is a vector-borne zoonosis, it is dealt by the National Vector-Borne Disease Control Program. If it is a non-vector-borne zoonosis, a direct zoonosis, it is probably covered by the Integrated Disease Surveillance Project. If it is a foodborne zoonosis, it is nowhere. So the Food Safety Authority of India, which was recently founded, is still struggling to put together a foodborne disease surveillance system in the country. So let alone foodborne zoonosis. So it's basically the absence of a program focus, which then leads to a very weak surveillance and limited response capacity. Again, we have some of the finest referral level institutions at the national level. Some of our laboratories are regional reference centers. They are global reference centers for different pathogens, different conditions, including zoonotic pathogens. But when it comes to subnational level and where the actual need is, the response capacity becomes very, very limited. So that sort of disconnect is also a major systemic challenge that we face. And these are more sort of glaring in case of veterinary sector. So for example, on the human health side, we have a nationwide disease surveillance system called the IDSP, or the Integrated Disease Surveillance Project. But on the veterinary side, we don't have any such kind of a surveillance system, which is regularly on a weekly basis feeding into a system all the disease events. There are some initial signs of these being put in place, but so far we've suffered in terms of gathering the surveillance data on different conditions, including zoonotic infections on the animal health side. And in the absence of a dedicated program focus and a weak surveillance, there is also a lack of evidence for decision making. So again, for example, India has this distinction of contributing to almost 50% of the global burden of rabies, as per estimates. But when it comes to the official figures, we report just about 200 odd cases from a country of 1.25 billion. So that's completely unbelievable sort of figure. If you talk about, say, bovine brucellosis, officially we report just about 200 plus bovine brucellosis cases on an annual basis. So that's the kind of limited evidence based on a weak surveillance system that it's not really informing the decision-making process. Now, what has been the national response? We see some initial signs of zoonosis and One Health approaches taking sort of recognition by the national program managers and policymakers. So what we have done is we have activated the so-called National Standing Committee on Zoonoses. This is a collaborative platform that had been created between the ministries of agriculture, which basically deals with the animal husbandry department, and the Ministry of Health in the late 80s. But in the absence of any motivation to take it forward, which in this case is typically some sort of a crisis, these committees, they sort of became redundant, and there was no activity. But in the aftermath of avian influenza outbreaks, the government reactivated this standing committee on zoonosis, and I'll show you in the subsequent slide what sort of mandate it has and what sort of composition it has. The other thing is that given the global developments and given the advocacy that has been done by different pressure groups, including groups like ours, the National Center for Disease Control has done a systematic disease prioritization, and they have proposed programs for intersectoral coordination and capacity building, and raising awareness about zoonosis amongst different stakeholders as part of its proposal to the 12th five-year plan. So basically the budgetary outlay of different ministries in the Government of India is done by the Planning Commission of India as part of its five-year plan. So all the ministries submit their proposals, and those then are put together, and that's how the funding happens. The budgetary outlays are done. So there's a clear mention of zoonoses, intersectoral coordination. I mean, the kind of proposals that have been made are obviously, subject to a lot of discussion and deliberations. But at least that initial step towards identifying this as an important element for addressing zoonosis and One Health issues is something that has happened. As I said, there are initial steps that the Ministry of Agriculture has taken to put in place a nationwide animal disease information system, which is called the NADRES. There were also some small baby steps by the research councils of the two sides, which have supported some small research projects, collaborative research projects on some of these zoonotic infections. But that is something which is still to be done on a sustainable basis. There have been some capacity building initiatives. For example, the Massey University from New Zealand, they carried out a One Health training. They conducted MPH courses for the senior ministry officials from both human and veterinary side, and these people got trained using a World Bank grant. So there is the national leadership has some One Health trained personnel in place. Now, how much will they be able to translate and operationalize their trainings is something that we have to see. But the commitment has been shown. People have been nominated, and they've gone through these trainings. There are a lot of these short-term training programs, like the field epidemiology training programs, which the National Center for Disease Control conducts. So they've started bringing the veterinarians as part of those field epidemiology training programs. It's not called the typical FATP-V, which is the popular acronym, but it is still an FATP, which has veterinary representation. There are joint trainings by the by the apex institution of the veterinary side, which is Indian Veterinary Research Institute, and the National Center for Disease Control. So they've been doing these short-term trainings. The Center for Disease Prevention and Control, the US CDC, has in the last couple of years, they've launched their Global Disease Detection Center in India. This is, I think, the 7th GDD globally. And they have launched something called the India EIS on the lines of their original EIS. Now, this EIS is again, it has a substantial focus on the zoonotic pathogens. And one of the priorities of the GDD in India, which has been identified consultatively through a consultative process, is acute encephalitis syndrome, in which Japanese encephalitis is a major zoonotic pathogen. So those sort of priorities are being identified. There is a greater focus on zoonotic infections, but these are some of the initial signs, and we still have to see how we'll be able to sustain these efforts. This is the institutional space for zoonoses in India. So I don't know how clear is this, but what we have is, so as I said, in the aftermath of the H5N1 outbreaks, we had the Joint Task Force on Pandemic Preparedness and Response, which was formed. So these are the bureaucrats, the highest policymakers who sit together, who basically give the mandate to the Joint Monitoring Group, which actually sort of designs and mounts the response from the national level. And the monitoring group actually meets quite often. Often as in when you have the event, then they meet probably even every other day or every day. So that sort of thing happens. But again, as I said, the focus is more on H5N1 outbreaks, how to douse those outbreaks, the fire over there. And then of course the standing committee, which has been activated. If you look at the standing committee, it is an intersectoral coordination committee. It is supposed to be that. It is chaired by the Director General of Health Services. Again, if you notice, and the member secretary is the head of Zoonoses from the National Center for Disease Control. And this has been the case throughout since it was activated in 2008. We simply haven't been able to pass on this leadership and therefore the commitment to the veterinary side. So you never see the Animal Husbandry Commissioner of India or the Chief Veterinary Officer of Government of India being the chair of this committee. So this has become an issue in terms of forging collaborations. And then you have various sectors being represented, including the wildlife sector, and we are also members of this committee. Basically, this standing committee gives policy directions, and it is supposed to promote intersectoral coordination and collaboration. But it ends up doing some half-baked operational research as well, which becomes an issue at times. And this is where the RCZI, or the Public Health Foundation of India, made use of the early mover advantage. We clearly identified that collaborative research between different sectors was becoming a major issue. the standing committee was not being able to translate this platform into more program and policy relevant research, which could involve both the sectors and could inform zoonosis control. So that sort of thing was not being possible from the standing committee platform. At the same time, there were also administrative silos. So even if there was interest, and there is actually a lot of interest, which we have witnessed as part of RCZI, the same stakeholders, they have a lot of interest in collaborating. But when it comes to collaborating from the platform of the standing committee, it becomes difficult because they are part of the administrative silos. So it's very difficult for them to share funds and collaborate and identify focal points. And then there are also competing priorities which don't allow them to sort of collaborate in a research mode. And a direct translation of research has to be informing the policies, and fair amount of advocacy. So that sort of research translation is also not something which is happening through the standing committee platform. So we made use of our position as a public-private partnership, which could provide a space outside of the formal space where all these stakeholders could come together. We could bring in additional stakeholders which are not possible to bring together on a formal platform like standing committee. For example, if we were to invite the Institute of Tropical Medicine, we can do that. The Government of India standing committee will not be able to bring on these partners. So that was the sort of flexibility, the advantage that we had given our status, and we worked very closely with the standing committee and its members to put together this initiative called the RCZI. And therefore, what was our response? So around the middle of 2008, we organized this brainstorming consultation where we called all these stakeholders who were part of the standing committee and some of the additional stakeholders, and we tried to understand from them about the need for a collaboration outside of the formal space, and what is it that this collaboration and this platform should be doing, and which could be a good agency to coordinate this platform. That's when PHFI got this mandate, and we were able to launch the Roadmap to Combat Zoonoses in India initiative. We were given 4 mandates. We were asked to foster multisectoral collaborations, undertake program and policy relevant collaborative research, contribute towards building research and response capacity, and also do a fair amount of advocacy and communication around One Health issues and the problem of zoonosis. The way we ensured program relevance, which we feel, we haven't had a formal evaluation of what we've done in the last 4.5 years, but we feel that the moderate amount of success that we've achieved in the last 4.5 years is largely attributed to the inclusive and participatory engagement with the important stakeholders when it came to identifying our priorities. So what we've done is we've put together an advisory group which has essentially the same composition as the standing committee with additional members. What we've also done is the member secretary of the standing committee, who's the head of Zoonoses or National Center for Disease Control, is also the co-chair of RCZI's advisory group. So we've created a link between the two, and making sure that whatever work we do is informed by the standing committee, that's the program managers and the policy makers, and it also feeds back into their requirements. So that sort of linkages have been done to ensure the program relevance of our work. So we've provided this space outside of the formal space for people to freely collaborate and interact and identify priority issues, and then make use of those discussions in their practice and also through our platform. We've also been able to develop and contribute to collaborative networks, both nationally and regionally, and also in the international networks. There are networks which we have put together. These are again multisectoral, multidisciplinary networks. There are networks in which we participate and contribute actively. And then there are networks which are formed as a result of the RCZI platform. So there have been networks where we are not part of those networks, but those have been formed because we sort of facilitated or galvanized those collaborations. This is just an illustrative list, and I'll not go into the details of the list, but there are definitely different formations and alliances at national and regional level, of which we are a part. Some of the recent developments have been the India Resource Center on Peri-Urban Zoonoses, which has been funded by the International Development Research Center of Canada, and we'll be partnering with the International Livestock Research Institute for the next 4 years to undertake very dedicated research on peri-urban ecosystems. We are also in very advanced discussions with Massey University, New Zealand, to set up the India One Health Hub, and also possibly translate into a South Asia One Health Hub. Again, this is going to be more of a research center which will foster communities of practitioners around issues of One Health, and it's going to be a regional level repository. The kind of research that we undertake is, as I said, we've tried to make it as policy relevant and program relevant as possible. And we've tried to make sure that research is not researcher driven, it's stakeholder driven. So, and in that spirit, the way we started doing our research, as a first step, we researched into what we need to research. That was the first step that we undertook. And how we did that was, we went to the important national level stakeholders from different sectors, human, veterinary, wildlife sectors, environmental sectors, and different professionals, different functionaries within these sectors. So policymakers, program managers, researchers, academicians. So we went to an entire range of stakeholders who would be concerned with zoonosis and One Health issues. And we try to understand from them that in the next 5 years, if that is the duration of the roadmap, then what is it, what are the priority diseases that we need to be researching on, and what are some of the priority research options around those diseases. And we came up with, once again, I remember in the first half today somebody mentioned that there was a difficulty in prioritizing the research questions that were proposed by different respondents as part of the exercise of prioritization. We faced a similar sort of problem. We came up with 103 research options. These were not questions, these were options. So we could identify within those options several questions. But we started with this set of 103 research options which were proposed by all these stakeholders. And we tried to see through an average weighted priority score, we found out that surprisingly, in the next 5 years, it's the health policy and systems research which the stakeholders felt is going to make the maximum difference to zoonosis control in India. Although the maximum knowledge gap is around basic epidemiological research, which means research around the burden of disease, the risks of different diseases. At the same time, we also found that social, political, and economic research, again according to the stakeholders, is going to make much more difference qualitatively in the next 5 years compared to some of the other types of research. For example, the genetic and biological research scored pretty low in terms of its ability to make a difference. And physical and environmental research again. So clearly there was an indication in terms of how we should be structuring our research agenda. The priority zoonoses that were given to us by these stakeholders were diseases like rabies, Japanese encephalitis, brucellosis, bovine tuberculosis, anthrax, rickettsial diseases, leptospirosis, and foodborne zoonoses. Again, this was a mandate which was given to us, and if you notice, most of them, practically all of them, are neglected zoonoses. These are not the zoonoses which really find a lot of visibility within the Indian context. So they wanted this platform to actually look into these issues which have got neglected and which they have not been able to focus on. So that was another important thing that we encountered. The kind of research options that were given to us led us to use multiple research methodologies. So starting from analytical epidemiology to disease modeling to qualitative methods. We also undertook geospatial analysis, economic evaluations, policy analysis. All kinds of research methods have been used in the kind of research that we've done. One thing I would definitely like to highlight is that through our experience, we've recognized that qualitative methods are a very valuable component of all the infectious disease research that we do, and they are extremely critical when it comes to informing the programs. So all our infectious disease research projects have a qualitative arm to it. So that is something that we've learned. And in the last 4.5 years, we've been able to mobilize about 23 odd grants, which have totaled to about $3.6 million. We've been able to publish about 16 papers in high impact factor journals with a cumulative impact factor of about 132, which would translate into an average impact factor of about 8. So that's how we've been able to show some kind of an output. In terms of examples of the policy relevant research, as I said, our research is categorized into two categories. We undertake systems and policy research. At the same time, we also undertake epidemiological research, which looks into the eco-epidemiological factors. So, and the way it has become relevant, the findings of our research, for example, our research priority setting was reflected in the 12th five-year plan priorities, as I mentioned, by the National Center for Disease Control. We evaluated the rabies control initiatives in the state of Tamil Nadu, which led to some of their future rabies control programs being informed. We also costed the cost of a complete set of rabies interventions for a typical Indian state. And that has led to a lot of discussions within India. We've been able to demonstrate, and we are hopeful that it will very soon be out in one of the peer-reviewed journals. We've been able to show that if you put together the animal side and the human side interventions together, it costs a typical Indian state 2% of the total budget of human, animal, and the municipal administration departments. So that's the kind of cost it requires to carry out a rabies control initiative on an year-to-year basis. So that sort of defies the traditional understanding that if you have more upstream interventions for zoonoses, which could be in this case by animal birth control or animal vaccination, it's going to be more cost effective. Well, that's not going to be the case. So we are actually challenging that assumption, and we'll see how we can sustain that sort of a challenge. But that has really led the national and the state level governments to think about what could be a more cost effective way of addressing the problem of rabies, in which India is definitely leading country. We've recently been awarded this Grand Challenges Award by the Gates Foundation, where we are looking at developing a One Health metrics, which our One Health colleagues will be very well aware of. So this is the flavor of the season or going forward. So similarly, we've had a bunch of epidemiological research questions. So that's how we have categorized our research based on what the stakeholders felt that these two types of research is going to make a difference in the next 5 years. And therefore, the exercise was not researcher driven, it was stakeholder driven. And just to give you an example of the disconnect between the kind of research that has happened, possibly because it was researcher driven, and what kind of research is required, we looked at, and this is also published in the PLOS Neglected Tropical Diseases. We looked at the rabies research, which was the kind of research that needs to be done, which was told to us by the stakeholders. The stakeholders told us that we need to focus more on research for improving existing interventions and health policy and systems research. This is what the stakeholders feel should be done. And of course, basic epidemiological research, understanding the risk factors and the burden of disease. But when we looked at the literature of the last 10 years and tried to understand what kind of research that has been done on rabies, we found that it was exactly opposite. So majority of the research has focused on developing newer interventions, whereas the problem with rabies control in India at least is that we have a vaccine, we have a very effective vaccine. We don't know how to deploy that vaccine and to make it available up to the last mile where people need. And those are priority research questions. Whereas our researchers have been focusing on newer antigens and newer sort of lab techniques to diagnose rabies and so on and so forth. So that's a clear research to policy disconnect. And that is the reason why in the last 3 5-year plans, we've never been able to convince the Planning Commission that we need a national rabies control program. It's only this year that with a lot of advocacy and a lot of pushing by different stakeholders, there has been some budgetary outlay for rabies control in India. But this is the kind of research to policy disconnect which leads to, especially conditions like zoonoses and One Health issues not taking a center stage. As I said, the research has to translate into policy and some of the other natural next steps. And what we've done is we've had this mandate of strategic communication and advocacy. We've engaged with different stakeholders. We came out with this quarterly newsletter called the Zoonoses Watch, which not only updates on the activities of the RCZI but also on topical issues. We try to step back from a disease-based approach and we identify some cross-cutting issues in these newsletters. Something which is also reflected in the systems and policy research. Systems and policy research tries to identify the cross-cutting drivers of zoonoses and One Health issues in India, rather than focusing on one disease and going into the biomedical aspect of that disease. And so a bunch of policy briefs, contributions to technical and popular publications. We've also been engaged in capacity building efforts, largely through training of junior researchers. So all of our research studies that we have a clear budget for junior researchers. I've exceeded a lot of time, so anyway. So going forward, we have plenty of opportunities for researchers, and we could discuss, some of the PhD positions and master's level research that we have. This is how we have evolved over a period of time. In phase 1, we did a lot of networking, identifying potential partners, identifying key knowledge and capacity gaps, and documenting those gaps. In the next phase, we went into establishing a national presence, generating more evidence based on those knowledge gaps, and researching on those knowledge gaps, and initiating policy discussions based on those evidences that we generated. And now we are in phase 3, into our 5th year, where we are more into evidence synthesis and policy advocacy. We are consolidating our networks, and very soon, in about 3 weeks' time, we'll have another vision workshop where we'll again call all the stakeholders and try to understand from them that this is, given this sort of work that we've done, what is it that you feel that we should be doing? What are some of the priorities that you would like us to focus on in the next 5 years? So again, going back to the drawing board and having a consultative process to identify priorities, making sure that they are policy and program relevant. Some of the future plans that we have been asked by our partners to play a larger leadership role at the South Asia level. And some of our upcoming research priorities would be urban and peri-urban zoonoses, food safety, and food-borne zoonoses, holistic evaluation methods like the One Health metrics, and so on and so forth. This is the last slide. Just to summarize our experiences, the positive experiences in the last 4.5 years have been that we definitely had this advantage of a public-private partnership mechanism that could facilitate collaboration outside of the formal space. We found that the research and academics are some low-hanging fruits. It is easier to forge One Health collaborations around these broader functional areas, and these could be good starting points in different settings. And in any case, the research around One Health issues and zoonoses has been largely fragmented, given the silos in which the sectors have operated. So even the evidence has not come together. So that's a good opportunity where we can forge collaborations and start looking at more sustainable mechanisms. We found that systematic identification of impact pathways has led to greater acceptability. So, going through this whole process of prioritization and coming up with a strategic research agenda, what kind of research we should be doing, how to ensure its policy relevance. So, having identified those impact pathways and then following through those impact pathways have led to greater acceptability. One positive experience has been that I come from a medical background. I'm a medical doctor, but just like our colleague earlier mentioned, I'm pretty much convinced about collaborating with the veterinary side. But some of our colleagues on the human health side are not as convinced. So, and we've done some studies which we can share in other discussions where we've clearly shown that the medical graduates know just about 20 to 40% of what they should be knowing about zoonoses when it comes to actually encountering a case of zoonotic infection in the clinical practice. So those sort of gaps are definitely there. But we've got enthusiastic support from the veterinary and wildlife side. And therefore, there are gaps, but there are also a lot of opportunities. In terms of not so positive experiences, I think, which was mentioned in the morning as well, funding has been a reflection of the global momentum. Especially the kind of diseases that we were asked to work on, these are really, really neglected diseases. So nobody would like to, invest into bovine tuberculosis and brucellosis, especially when you can do nothing about it, especially in the Indian context, especially for the tuberculosis, bovine tuberculosis. So those sort of issues we've also suffered, but given the program and policy relevance that we were able to ensure throughout our 4.5 years of work, I think we've been, at least successful to some extent in mobilizing some funding. It's been difficult to convert, especially in the earlier days of our work, to convert the traditional thinking of a very biomedical approach, which got reflected in the research policy disconnect, and a disease-based approach which promotes silos. So our traditional thinking of the stakeholders has been that unless you're talking about disease, it doesn't make sense to them. So if you talk about cross-cutting issues, that becomes a very different language. So people would not accept that kind of a research question or a research project. But the moment we came up with those findings and how they were relevant from a policy and program perspective is when we started, they started identifying with what we were saying. So, but largely that is still a problem, and it tends to get reflected in a lot of research, both nationally and internationally, that is conducted on One Health issues. We focus on a disease and in a very biomedical, using a very biomedical lens. And the culture of information is still developing, so it's still difficult to collaborate. We haven't really reached there. So these were some of our experiences, and thank you very much. I'm happy to answer questions.
Okay, please stay there, yes. Okay, thank you very much for that presentation. We have time for maybe 2 or 3 questions before we move into a short coffee break. So please go ahead if you have any questions regarding that presentation. Yes, please.
Thank you, Dr. Kakaka, for this presentation and sharing with us all this information. Very, very, very interesting and very important. And I want to know, you have talked about this roadmap. In which step you are now?
So we started in 2009, middle of 2009, and we are right now in the phase 3. So phase 1 was initial 1 year where we were developing networks, and we were doing some basic studies to identify knowledge and capacity gaps. Basically prioritizing our work. What is it that we need to be working in the next 5 years? So that sort of activity, going to stakeholders and trying to understand from them. So that is what we did in the first 1 year. We documented everything, and then based on that systematic documentation, we launched into phase 2, which was roughly about 2 years. I mean, we didn't really sort of say that, okay, this will be phase 1 and this will be the duration of phase 2. But typically we spent about 2 years or so researching on those priority issues which had been identified, the most critical ones, and also addressing some of the capacity gaps. So a lot of that actual research work was done in the next 2 years, 2.5 years. And now we are in the 5th year where we are now consolidating everything based on whatever we've done in the last 4 years or so. And as part of this consolidation, we will again go back to the stakeholders which gave us this mandate for next 5 years. and we'll ask them what is it that we need to do now going forward in the next 5 years. So to answer your question, we are actually in phase 3. Yeah.
Okay, do we have any other questions? Marleen?
Thank you, Dr. Kaka. This morning the point was raised by colleagues, and it was also one of the results in the survey, that the collaboration between medical and veterinary profession is difficult. You give a list of reasons why it is difficult in your experience, but what was raised was that the medics mainly, they look down, so I interpret it in that way, they look down on the veterinary profession. So my question is that the case in India? What is your experience with that? And what are the ways you see to get beyond that, to change those attitudes and perceptions between professions?
Right. No, I could actually completely identify with the discussions this morning, because we face similar sort of situations and similar kind of perceptions on the medical side. It was only after the bird flu outbreaks in India that the veterinary side was brought on board. And even subsequently, when you have H5N1, you'll have this, the joint monitoring group, it will invite the veterinary side. The moment you have H1N1, they are missing from the table. The moment you have CCHF, you'll again have these people on board. If there is another zoonosis like rabies, veterinary side is not interested. So those sort of things are definitely there. So that difference in terms of the stature and perception of the veterinary side being not as important, or the second grade sort of professionals is something which we also suffer from. And I also identify with the point that was made in the morning, that a lot of it is being driven by the kind of education system that we have. We did the study in which we assessed the knowledge and practice levels of medical graduates when it came to zoonosis. We assessed the knowledge levels of the final year students who had just finished their microbiology, and we assessed the practice levels of interns and recent graduates when it came to zoonosis. And on either side, these were medical graduates from some of the topmost medical schools in the country, sowing the seeds of these professionals. So we need to address this on the medical side, definitely. We also looked at the current medical curriculum. How does it treat the topic of zoonosis in the medical curriculum? Again, the issue is it is so fragmented that it is not surprising that we got the kind of results that we got. So the curriculum itself is flawed. We talk about individual pathogens, but we don't put them together as a group of pathogens which are zoonoses and which have an animal source and which requires collaboration, and there is a certain way you have to approach them and a certain way you have to suspect them. So that sort of thing is missing. So I think to answer your question briefly, we need to address the problem at its roots. That's going to be a long-term strategy. Refining the medical, or revising the medical curriculum, and approaching these medical graduates in a different way than the way we've been approaching them. And as a short-term strategy, I think it's important that researchers and academicians come together and generate more relevant evidence and package it in such a manner that it can feed into short-term capacity building efforts, joint trainings, joint sort of field exercises. For example, what we've done is we've developed this short-term training program where we use a case study method. We don't go into individual zoonoses. We step back from the disease, and we have a competency-based training program where the competency is around joint outbreak investigation and developing a joint action plan to deal with an endemic zoonosis. And the human, veterinary and wildlife professionals have to necessarily sit together in teams to answer those questions and come up with solutions. So having these short-term strategies along with long-term programs is something that is going to bridge this gap. The other thing that we often forget is the collaboration around knowledge gaps. So collaborative research is something that also kind of converts these people and makes them understand of the limitations and constraints and strengths of the other sector. So if there are opportunities, for example, in our study on Japanese encephalitis, we had an entomologist, we had a qualitative researcher, social scientist, we had a veterinarian, we had a lab person, we had classical public health epidemiologists, we had communication experts. So all of them sat together. And there were times when we had close to 150, 160 years of experience at one time in one given room. And there was a lot of this tension and back and forth and a lot of temperature that used to go up. But at the end of it, we are a very different lot at the end of those 2.5, 3 years of that eco-health research that we did, because we now understand the other sector much better. And in fact, we started stepping back from the language of Japanese encephalitis. We started speaking in the language of ecosystems or a biotope. So that became the language for all the professionals. So I think these are some of the steps which we have to identify. And these have to be, as I said, research and academic collaborations are low-hanging fruits. It's easier to forge collaborations and convert and promote collaborations around these functional areas, rather than straight away going for the most difficult thing, which is having a joint program, zoonosis control program. So if the cultures are very different, if there is a lot of mistrust and communication gaps between the two sectors, I think it's important that we have short-term and long-term strategies on research and academic side to make a start, and then gradually, once you have these people becoming more aware of each other, that's when you translate them into full-fledged programs. I think that was a very convoluted answer to your question.
Okay. Thank you very much, Dr. Kekar. I'm afraid that's all we have time for at this point. Please join me in thanking Dr. Kekar for a great presentation. Okay, so short coffee break now, about 10 minutes. Let's see if that works. And then we'll come back for Tanguy's presentation. Thank you. All right, so we'll continue the session with our second speaker, and I'm sure that most of you will know Tanguy, but I'll introduce him nevertheless. Tanguy Marcotti is a veterinarian, and he worked at the ITM for 20 years, where he worked on neglected zoonoses and also was one of the proponents in the last couple of years in terms of getting the One Health approach going within the institute. He's also coordinated a project which was funded by the European Commission, which basically provided an online learning platform on the One Health concept for postgraduate students. He's also a lecturer in veterinary parasitology at the universities of Namur and Louvain-la-Neuve. And currently, he's running his own enterprise in veterinary epidemiology and international animal health. Tanguy, the floor is yours.
Thank you very much, and thank you to the organizers for inviting me to make this talk, which I hope to be practical. And I selected a few examples to illustrate my ideas. I'll try to explain what transdisciplinarity is. We talked a lot about intersectoral collaboration, which is important, but here I have just an added idea that on which I would like to emphasize a little bit. This is just a reminder. The One Health and One Medicine concept comes from a veterinary epidemiologist. The One Health has often been seen as being driven by the veterinary profession, and that's maybe the reason. But in actual fact, it's relatively easy to realize that humans and animals share the same biological template, and therefore all disciplines such as physiology, immunology, pathology, surgery, medicine, epidemiology, and others are very similar in human and animal health, and that is almost trivial. In our case, we focus a little bit more on zoonoses and neglected zoonoses, and to some extent we also worked on drug resistance of pathogens to drugs. But what do we mean by transdisciplinarity, and why is it important? Transdisciplinarity is seen as epistemological perspectives that offer unique that result from a unique collaborative effort and distinct from results of any of the cooperating disciplines. That's a difficult definition that also comes from UC Davis, the same university as Professor Schwab. This is actually what One Health is not. One Health is not about veterinarians doing the job of physicians, and it's also not physicians doing the work of veterinarians. We believe that transdisciplinarity and One Health occurs when 1 + 1 is greater than 2, meaning that the output, the results of a collaboration is more than the results that could have been obtained by individual efforts in each of the two sectors. Having said this, how can this be applied in infectious diseases? I chose 3 examples, not necessarily in my actual competences, so you will bear that with me, but I think they are important and are good illustrations of what we are talking about. First, influenza, and you all heard about avian influenza outbreaks taking place in Asia first, and then spreading in different parts of the world. Rabies, as a cosmopolitan and sporadic disease of humans and animals as well, and echinococcosis, or cystic echinococcosis more specifically, which occurs in endemic areas in some rural communities. But there are many other diseases, including emerging diseases of humans, and including animal killers, which can have important socioeconomic impacts on human health and well-being, and even highly contagious diseases require stamping out, for instance, and having strong psychological effect on the owners. The first disease, avian influenza, is actually not neglected zoonosis. It can be, and it is a zoonotic disease, but it should not be considered as neglected given the amount of money that was spent on this outbreak to control it, and also given the number of cases. So this is just a reminder. It's a viral disease of poultry and wild birds spreading from Southeast Asia. It started in 2003. And it spread mostly through trade routes, but also through migratory routes of birds. And it's a zoonotic risk, zoonotic infections transmitted directly from birds to human beings. But there is a risk of human-to-human transmission if the virus adapts, or if there is a recombination of the virus in a given host. You heard, and everyone heard a lot about that outbreak. It's not only scientists, but also I think anyone in the world also aware of that outbreak. Yet, since 2003, only 380 fatalities occurred in 15 countries, a total of 641 clinical cases, which is extremely low given all the noise that was made on on this disease. So there were great public awareness, a fear of the disease, prompt reaction of OIE and FAO, and I think they were right in estimating that it was a serious issue, and they managed to convince the World Health Organization, WHO, and that was the first example at international level of intersectoral collaboration between WHO, OIE, and FAO. H5N1, as you know, or at least the risk of outbreak was eliminated through huge resources, including or used to improve the surveillance of human and animal cases, sanitary measures, and including the management of marketplaces, and vaccinations were also proposed in humans and animals with the effects of which are not very clear. So what would be, or what are the collaboration needs in terms of H5N1 control and research? So first, this intensive interaction between domestic animals and people in some areas, and it's therefore important to better understand the transmission from one species to another, and to the human species more particularly. And there is also rapid spread of the virus caused by trade and wild bird migrations. So trade is more like business and use of animal resources, involving possibly the veterinarians, but not only, all people working in the animal production sector, and wild bird migrations would require the use of ecologists and ornithologists possibly as well. We need to operate at human health level, and that's the role of WHO. We have to operate at animal health level, and that's the role of the OIE, World Animal Health Organization, and we need to work as well at FAO level for integration of animal production system, and that's only then that transdisciplinary could possibly occur. The example of rabies, I think, is also interesting because it's endemic in many developing countries, and I'm talking here of urban rabies, which should be discriminated from sylvatic and bat rabies occurring in developed countries, including Europe for sylvatic rabies and America for bat rabies. It's a disease of most mammals, and including man, and dogs are the main source of infection. This picture reflects a case of a rabies case in the dog, and I think somehow it highlights the problem. The person simply came with the rabid dog to the veterinary clinic to have it treated without knowing probably that it was rabies. Even if he knew it was rabies, he was obviously taking great risk for himself and also for his direct environment. I must say that for myself, it's the only real case of rabies that I ever saw, but it was spectacular. Rabies is present in more than 150 countries, and this is data from WHO. Each year, 55,000 human deaths occur, mostly in Asia and Africa. 40% of the people bitten by suspected rabid dogs are children. And every year, that's also an important figure, I think more than 15 million people are treated with post-exposure vaccination. The impact of rabies, so this is the spread of rabies throughout the world, and you can see that it's mostly Africa and Asia that are affected by this disease. Notwithstanding the morbidity and the mortality of rabies, and keeping in mind that rabies is 100% lethal, rabies has got great medical cost given the treatment of diseased patient and the post-exposure prophylaxis, whether the patient was indeed inoculated with rabies or not. So that's a very high cost related to the exposure of people to dog bites. Psychological impact as well of rabies, the deaths of relatives, the fear of dogs are also important things to consider, and the loss of dogs, pets, and other animals, so including livestock, for instance, that can also die from rabies. This is also, to some extent, losses due to rabies. If we want to control rabies, if we want to address rabies, the dog is really the keynote in the whole system, and vaccination of dogs should reduce the risk to almost nothing. Vaccination of the dogs with a coverage of 70% at least, and the vaccine is actually very good. It can protect the dogs for up to 5 years, and depending on the legislation, boosters after 1 to 5 years are proposed in the different countries. But then comes the problem with the dog vaccination. First, who pays the vaccination? How to vaccinate the wild dogs, the feral dogs, the dogs that are in the streets, and even the owner dogs are sometimes very difficult to catch and to receive the injection. So how can we manage that, and how can that be done? And also the question how to control the populations of dogs. But if dog populations could be controlled, and if the dogs remaining in the society are vaccinated, rabies, the problem of rabies would be solved. This need for education and awareness, and especially in the children, for early detection of the rabid dogs and detection of the risk, for the control of the population of dogs, for the vaccination of dogs, and for the post-exposure treatment. This need to work on the medical care, but I think on this one there's not much to do, because when you see the number of people that are exposed and the number of deaths, I think the ratio is quite good in favor of a good medical care. And finally, capture and quarantine of suspected rabid dogs, and that's also something important to do, to confirm whether the patient was exposed or not to rabies. And then here again, we can try to identify how and who should do what. Obviously, the veterinarians should deal with the dogs and the dog vaccination, but still, veterinarians might need another sector to contribute, and for instance, ecologists. And the issue of the dog ecology, I think, is important to understand how they reproduce, including in the wild. We also need to understand how to impact the population of dogs if we want to neuter them, to sterilize them, for instance. And obviously, sterilizing females is more effective, but also more difficult than sterilizing males. Shall we or should we kill wild dogs or feral dogs? Some studies showed that it's not efficient, that if you kill the dogs, some other dogs will come, but most importantly, it would be more useful to capture the dogs, to sterilize and vaccinate them, and then to release them back in their environment. Hospitals would have obvious roles to play as well, but importantly, they should report suspected rabies cases to the veterinarians so that they can possibly act on the dog population. The municipality should play also its role in terms of waste management, because dogs cannot survive if they do not feed. That's obvious. And wild feral dogs can simply not survive and reproduce if there is no waste to feed. So simply the management of the waste would help tremendously reducing the population of dogs. Extension work and also social scientists would probably be very useful to better understand the perception and acceptability of the risk, and also of the management of the dog populations and vaccination. I will end. This is my third example: cystic echinococcosis, which is an endemic disease caused by a parasite, Echinococcus granulosus. It's a cestode, a bit like the tinea, except that it's much shorter, it's much smaller. It's a very tiny worm of a few millimeters that you can see here on this slide. And the adult stage is found in the gut of dogs. So here dogs play again a very important role. The problem is that the eggs of this parasite are released in the environment and swallowed by herbivores, mostly sheep, but also other species, and including man. And in those intermediate hosts, the parasite develops and causes big cysts, sometimes weighing a few kilograms. So, which means it's a big volume on important organs such as liver, lungs, and sometimes other organs. Animals do not seem to suffer so much from the infection, but it causes a very serious disease in human beings. You see the geographical distribution of this disease, and you can see that it's closely related to sheep breeding. And South America with a lot of sheep breeding, the Northern Africa, and the Middle East are all areas with large sheep breeding. Main causes of this zoonotic disease: dogs are often free and largely unfed and untreated. More important, offal are given to the dogs, and which means that they have a chance to feed on infected organs, which will result in the production of large number of adults in the intestine of the dogs. Dogs have free access to grazing areas, which mean that they will disseminate the eggs on the pastures on which the herbivores will feed and maintain the infection. And people are in direct or indirect contact with dog feces, because that's where the eggs are found, but are also found on the hair of the animal and in the house if the dog lives in the house. People get infected in direct contact with the dog itself, or by the consumption of contaminated vegetables or drinking water. So there we did a study in Morocco a few years ago. And I think this slide is quite interesting. You see on the left the life cycle of the parasite, as you can find it in the books, in the textbooks. So this is the real life cycle as I described, and possibly, which I've not said, the weather might have an influence on the survival of the eggs in the environment. So obviously, warm and dry weather will be detrimental for the transmission of the parasite from the dog to the intermediate host. And on the right, you see the life cycle as perceived by the communities in High Atlas in Morocco. Interestingly, they are aware that diseases can be transmitted from dogs and also cats to human beings, but they also fear to get infected by the sheep by consuming mutton, infected sheep, and they also believe that both humans and sheep get infected when the weather is not good, or when there rains. I'm as a European, I say when there is rain, the weather is not good, but maybe the weather is good when there is rain. So I think it's quite interesting because all components are there, but the puzzle is not in the right order, and we possibly need to take that into account if we want to adapt our control strategies. If echinococcus is to be controlled, we have to work on dogs, sheep, and humans. And here I mentioned sheep, but basically all ruminants could be involved as well. Dogs avoid feeding on offal. Chemotherapy can be given to the dog on a regular basis, but that needs to be done regularly because every time the dog gets infected, it can produce again new eggs, and the dissemination and the contamination of the environment should be also avoided, controlled. Sheep, they are not very sick, but important organs or valuable organs are lost due to the infection. So there's an economical loss here. There's an important need of offal management and management of infected organs because people don't like to eat them once they are contaminated. So what do? They throw it away, and where does it go? It goes to the dogs, which is exactly what should not be done. And sheep could possibly be vaccinated, and there are some research programs, and the idea is here to break the life cycle of the parasite. How to control the disease in humans, or to prevent humans from being infected. Contacts with dogs should be avoided or reduced, but can you really impose that to people? Contaminated food, contaminated water, but that's again difficult to avoid. This is an example that I borrowed from my friend Hamid Saibi, with whom we worked in Morocco. This is High Atlas in Morocco, and you can see this snow. So yes, there is snow in Africa, and people actually go skiing in the snow. And the problem is that people going skiing, they also need to feed. There are some restaurants up there, and during the winter, they attract a lot of dogs feeding on the waste in the ski station. And the dogs, they defecate in the snow, and then when the snow melts, it just goes down in the valley, and it's collected by the people to make food or to drink. And it is suspected, but not proven, that this is an important way of transmission of the parasite in that region. This obviously is not a question that veterinarians or medical doctors will be able to answer on their own. They need support from other disciplines. So here, this is a summary again. Who should do what? Veterinarians should basically, obviously, deal with dogs and sheep. Communication with other sectors is always welcome, of course. The medical sector should improve the surveillance, given the fact that it's a very chronic disease, and possibly improve the therapy as well. I didn't mention that there's a therapy in human beings, but it's expensive and very debilitating. It's done by removal of the cyst through surgery or different methods. Municipalities here have a very important role to play in the management of abattoirs, and possibly even construction of abattoirs, and the management of the waste. Always, because any waste can attract dogs, but more specifically the infected organs, of course, which should certainly not be given to the dogs. And finally, social scientists could be useful for improving the perception and understanding of the disease, and identifying the role of the dog in the society, and identify acceptable methods of control. So I come to the conclusion: transdisciplinarity, yes, but how? First, important, I think, and I hope I demonstrated, that we need excellence in each of the disciplines. So it's not a matter of trying to do each other's job. It's more in being good in your own work, and be prepared to collaborate with other sectors, and make the other sectors aware of what you are able to do and what you are able to offer. I heard this just before my presentation, that veterinarians were complaining not to be well considered by medics. I'm not sure it's completely right. Medics have a lot of considerations for vets they find useful. So if you are not found useful, either you are really not useful, or you have to explain why you should be seen as a useful person. Identify potential added value. Remember that equation: 1 + 1 should be greater than 2, otherwise one health is useless. And how can that be done? Joint lectures at undergraduate levels, more interactions in undergraduate levels, just to try to identify the collaboration needs and collaboration opportunities. And this should lead the new scientific generation to have the competence to develop genuine control strategies, not simply copy and paste what is done elsewhere. It's important to try to develop genuine and adapted control strategies, and that requires some research, obviously. and jointly with the different sectors involved, identified the research needs and priorities. I thank you for your attention, and I have here a drawing that was a picture that was made a few years ago after a colloquium we had in Antwerp on the collaboration, intersectoral collaboration between the medical and the veterinary professions. And we actually have a booklet that I have there. That was published 3 years ago, but we distributed that in the different fora. Maybe you have a copy, but if you don't have a copy, we don't have any hard copy anymore, but you can download it from the website of the strategic network. Thank you very much for your attention.
Okay, thank you very much, Tanguy. Is this on? Yes. Can we have maybe 2 or 3 questions from the audience before we move on? We don't have that much time anymore, but we should be able to handle 2 or 3 questions on Tanguy's presentation. No urgent questions? Yes?
Just to add a comment about the hydatidosis. I'll take the example of Morocco. We are actually not talking anymore about each disease by each, we are talking about a cluster of disease, dog, leishmaniasis, hydatidosis, and rabies. Because it's very, very difficult to go each time to do injection, to come back to do, to give antiparasites and things like that. So actually people are thinking in an integrate control for these 3 diseases that comes from dogs. The place when we had this work, Séverine, Tanguy, and me, in the Atlas, in the mountains, we have been working in that place for at least 15 years. So, besides doing research, we brought to these people other people that do water and agriculture and culture and everything. So people in that area were, kind of pushing them to grow in their mind. They trust you, they believe on you, and they believe that you brought something new besides coming with injection or giving them antiparasites. So we give them other things beside that. And now there's 25 families without dog. They don't need dog anymore. They are convinced that they don't need dog. So that's kind of things that should be, developed beside saying, oh, can do this and this and this. So yeah, it's a package with a lot of things, and mainly sensibilization and vulgarization of things. Thank you.
Yeah, very briefly, I do not disagree at all with you about the creation of clusters to address several diseases in a specific environment. And I think when you want to deal with diseases transmitted by the dog, for instance, it's obvious that it's better to address them all in the dog, but that certainly does not remove anything from the need for intersectoral collaboration, where you can still work disease by disease, because maybe they do not have all the same impact on human health, for instance, and maybe some of the diseases would require some sectors which are not required by others. So maybe it's better to establish the framework by disease, by problem, and then within a sector, then you can see how you can possibly, or you can best address it.
Any other questions? Yes, please, there at the back, yeah.
Thank you very much. Perhaps I lose something you presented. My question is, did you identify some barriers which is against the collaboration in transdisciplinarity? This is the first question. And the second one, what do you think has to be addressed in principle according to this collaboration? just sharing information, or perhaps something in regard of sensibilization, or other things which could be sharing according to the collaboration?
On the question if we experienced failure in intersectoral collaboration between the veterinary and the medical professions, yes, I can say yes. And for instance, we tried to work on brucellosis and tuberculosis in Africa, and medics were not interested. But we found why. It was very low in their list of priority. And especially zoonotic tuberculosis, for instance, is a very small problem compared to human tuberculosis and the drug resistance issue. So whether some cases of tuberculosis were indeed caused by animals was not seen as a serious problem by the medical profession. The same with brucellosis, but there we might claim that there is an underestimation of brucellosis in human beings, which could be possible. That's why it's important that the medical profession possibly looks as well in its own capacities and simply wonders whether they have considered that disease as a potential cause of fever in human beings. So this issue of underreporting, or said underreporting, and very low in the priority list, I think that's an issue of discussion, and but we should discuss it openly between the medical, between physicians and veterinarians. And I think in Africa, veterinarians are very puzzled because those diseases, brucellosis and bovine tuberculosis, are not controlled, and the theory, I say the theory says that if a disease which is present and that is not controlled should cause human cases and should be seriously considered in humans. But it might not be the same everywhere. It was like that in Europe, but maybe it's not the same in Africa or in other places.
All right,
so that's why I'm advocating for scientists to look for genuine solutions, not copy and paste from elsewhere.
Okay, thank you very much, Tanguy. I think we'll keep it at these two questions because we need to move on. Please, let's thank Tanguy for his presentation and for his time. What we would like to do now, it was touched upon earlier this morning when we had our business meeting for the Strategic Network on Neglected Diseases and Zoonoses. One Health is kind of implied within the name of that network, but we might be able to argue that we haven't really done enough in that sense, that we haven't really carried that strategy that is inherent to One Health far enough in our network. So what we would like to do now is just with the people that you're sharing a table with, just maybe have a think about, well, I guess there's two questions. One question is, in how far should we drive the One Health strategy as being an integral part of our network? So, for example, should we even rename the network to One Health Strategic Network on Neglected Diseases? Or should it be something that is more implicit within our network so that we, I don't know, we apply some of the strategies that have grown within this whole concept. So that's one question, in how far should we drive this in our network? And the second question is in terms of practical strategies, how can we support these kind of intersectoral collaborations that are required within this kind of a philosophy? How can we, in practical terms, build that within our community? Well, it's a community, but it's mainly a network. So those are two things that we'd like you to brainstorm about for the next 5 to 10 minutes, and then it would be great to get your ideas about that, and so we can use that as an input for further discussion further down the line. So if there's only 3 of you at a table and there's only 3 of you here, maybe you can just band together and join other tables. Doesn't really matter how many groups we end up with, but it's always good for the discussion to have more than 3 people at one table. Okay, so go, 5 to 10 minutes. So what I suggest we do is we just go table by table and just get an idea of the things that were discussed at the different tables, and I'll just note them down and we'll take it from there. So maybe we can start at the back with Madeline. Do you have a microphone? Or?
It's the first question, but and we are halfway answering the second question. But the first, do we agree? I think we agree that that the name does not really have to be changed. That it's more about the approach that we have to, the message that we have to give. But if we call it a strategic network on One Health, then it sounds like we only focus on One Health, and it's either too broad or too specific. The way it depends on how you look at, how you define One Health. So we would prefer to keep it on neglected diseases. I myself find it, because I don't know if we all agree on that neglected diseases and zoonoses is actually also not true, because zoonoses are neglected diseases. But I think this is a good compromise.
Okay, and on the second question, was there any thoughts there?
Huh?
So in terms of practical strategies within the network for supporting the kind of collaborations that are inherent to the One Health strategy or philosophy?
I give.
I don't know whether it's relevant. We haven't discussed it actually, but I think in the context of ITM, that is a good opportunity. Having vets and medical people and scientists together. So I think that promotes the concept of One Health, and then also in the partner institutions, having it very wide and broad in Africa and Asia and in Americas. And also in this network there is a diversity of disciplines and having medical people and vets together. So I think there is a lot of opportunity to exploit it a little bit better through the network, and strengthening the network. And they need a particular strategy. You've alluded to some of those actions this morning, and I think this network is only one of many other networks, and then to partner up and make an effort through the office to be enriched and with other networks doing similar things.
Yeah.
From an African, Asian, American perspective.
Yeah. Okay.
And I think that will help a lot.
Okay, thank you very much for that suggestion. Thank you. Let's move on to the second group, back there with Narayan.
For question 1, we agree with like the previous group said. We do not need to change the topic. We do not need to change the title. The title is fine. For question 2, we would like to add that like how we have the South-South grants, we could even have some grant specific that would include medics and vets. So we could have, and policy and we could include something that would include related to the policy strategy. So that would be a good option.
Yeah.
Thank you.
No, thank you. Was there anything else? No, okay. Let's move on to the next group back there with Jan and Marianne.
Actually, we could not finish our discussion, but for the first part, we are still agree that this current name is okay, because it has a wider scope of activities rather than using One Health concept, because One Health probably might limit the activities. And for the second part, we actually could not start discussing. So that's only one answer for us.
Wasn't discussed? There's no ideas within the group now on how maybe following on some of the previous comments?
Yeah, just following up on the response to the first question. I think there is still a lot of confusion in terms of how do we define One Health. I mean, there have been numerous discussions globally, but we are still to arrive at a consensus what sort of limits One Health. So it will be wrong to synonymize One Health with zoonoses. I think there are discussions where even plant diseases and environmental issues, even issues around pesticides and toxins in the environment are being included in the discussions related to One Health. So in that sense, I think One Health is a much broader umbrella. But given the fact that we have still not been able to define the limits for One Health, the scope of One Health, I think it's important that we retain the name of the network and we say that we focus on neglected diseases and zoonoses, which are clearly defined, which brings a lot of focus. At the same time, we follow a One Health approach. Rather than having One Health as a framework, which we can loosely call it as an approach. So we would retain the name of a network, but at the same time we'll follow a One Health approach. And the reason why we need to mention One Health approach, because of the bandwagon effect. There is a big bandwagon which is talking about One Health, and that's the movement, and that is the movement which has actually even pushed eco-health out of the the momentum. And the other point I would like to mention, which my co-speaker mentioned, transdisciplinarity is very, very central to the eco-health concept, which has a much longer standing in terms of actually practicing research in an eco-health approach rather than One Health. So I think retaining the name of our network, at the same time mentioning that we'll be following a One Health approach and the principle of transdisciplinarity, highlighting these two traits of our network would be a good way to sort of move ahead. Yeah. And in terms of second question, I don't know if I understood it correctly or not, but I think from the morning discussion, one thing which was not clear to me is, how did we arrive at identifying these institutions which are part of the network? Was there some sort of a criteria, or was it some sort of an interest group which led to these institutions coming together? And therefore, the kind of work that has happened in the last 3 or 4 years as part of this network, there was some mention of some prioritization that was done, but was that a prioritization that was part of the group exercise, or was it a much wider consultation? So I think in terms of future strategies, one thing could be that these institutions could possibly engage with their national level stakeholders. I mean, I'm not sort of trying to promote the strategy that we followed, but I think that gives a definitive direction. At the same time, we can stick to our principles and the nomenclature.
Okay.
So identifying priorities systematically, and then that could be one strategy.
Yeah, thank you very much for sharing those thoughts. Let's move on to the next table.
Well, we also think that focusing in One Health, it would be better because there is many examples where the interaction between the surround and also the animals and the vectors, they can serve as a reservoir. And if you control one, it would be another one. In the example of the rabies, there is raccoon and other animals that can have that problem. Also, in the birds, when you're traveling, they are traveling and they migrate from one place to the other. They carry virus, and then there is an environmental problem there. And it would be a good thing to join with all the veterinarians and then try to find solution. That's why we really think the same thing happened with men are going in a selvatic place where they never has been before. Then they got the leishmaniasis in that way, either visceral or cutaneous leishmaniasis. And that interaction is very important. And then what happened with those things, and also veterinarians, also biologists, should participate in the thing. So the concept of health, it would be wider and also better.
So definitely a need for that kind of interdisciplinary collaboration. Were there any ideas on how within the network we can stimulate that? Severin, did you?
Yeah, we reached for the Cuban, they are already in fact reporting all the cases of zoonotic disease among the medical sector, but they really are looking for more training on One Health and how to in fact use the One Health approach in their context. So it's more focusing on training. If there is a call, they will look more to apply it in form of training. Yeah. And about the name, our colleague Herman Songo say that it doesn't see the purpose to change it in One Health, or instead of maybe now it's really fashion, so we will maybe attract more advocates. No, be more in the loop. But at the end, like Manish mentioned, maybe the name, the concept will change, but not the approach. So it's more to focus on the approach and not to change the name of the network.
Okay, thank you very much. Last group, please. Any ideas, any suggestions?
Agree with all what the other groups have said regarding the first question, and the second one, actually we also didn't have a lot of time to discuss, but then there was something like we felt that within our own context, within our own environment or in the individual countries, we may have to look at it at which stage we are in. For example, it may so happen that in my country, I need to first sensitize the other stakeholders. What is the One Health approach? And somebody may be in a different level. So I think regarding the network, there could be some support, either technical or even funding, to help each of these partners to take such initiatives, at least. And that could be like an example for the region itself, for the country itself to take forward. That's personally what I felt, what some of us had felt at that time. But maybe somebody can add what they want.
Thank you. I would just like to say, and maybe add to comment to what Katia Polman said about the name on zoonosis. So zoonotic diseases are not necessarily neglected or considered as neglected. The official list of WHO contains 8 diseases, and obviously there are much more zoonoses than those 8. And but I might agree, and obviously I have nothing to say anymore, that the network is focusing on these 8 neglected zoonoses. But we should make sure that we are not missing a number of other zoonotic issues, and also, well, maybe remember that those neglected zoonoses, we tend to say sometimes, or to ask, are they neglected or negligible? You might have the same question with neglected tropical diseases, but sometimes these diseases are not the most relevant, even for the medical sector.
Okay, thank you very much. Yes, one more. Yes, Victor.
Yes, maybe, okay, I agree with keeping the name of the network, but I was thinking maybe we can say the strategic network on neglected diseases, then dash One Health. We remove zoonoses, I think. That's one. And then for the second question, I was thinking, because there are certain programs where, say, Ministry of Health has collaborated with the Ministry of Education. So I was thinking even at this level, we can have, say, Ministry of Health collaborating with the Ministry of Agriculture or Livestock, and the collaboration starting first at the highest level. Because it's difficult, say, for me, medical doctor at this level, to approach a vet. But if the collaboration is, say, pushed by the topmost level, I think the two disciplines can work together. And as I was thinking, maybe even this network can push that agenda by, say, bringing the top civil servants in the two ministries to, like what Professor said here, to sensitize the top people before coming down.
Okay, thank you very much. Unfortunately, well, it feels like we only just started this discussion, but we'll have to leave it at this because I know they're going to be using this area for the official opening ceremony, so they want to clean us out of here as soon as possible and start reorganizing for that. But I'd like to ask Suman to close the session with a few words.
Thank you, David. I think we've had a very nice and fruitful day. We have discussed on various aspects of this network, starting from reviewing what has been done and what we liked and what we wanted to be changed. And that has been good guidance to frame the next Framework 3.3 transitional period activities for from 2015 to 2014 to 2016. I thank all of you for your contributions and comments, which has really helped and enlightened a lot of us. And then we came to the presentations by our young research scientists who had received the award from the network, and I really liked the way we interacted with them, because most of the times, you know, when we go to a conference, we take a lot of time to prepare the posters, but hardly anybody comes and interacts. So this, I think we pushed them a lot. They had to repeat it 4 times, but I think it was a very good exercise, and I think also we also learned something more than what we already knew. So I think we should try to continue in the same spirit and same manner. Now, I would really like to thank the 2 speakers in the afternoon, Tange and Dr. Manish Kakkar. Well, actually, I really liked the lectures because it showed us, giving us an examples how we could approach the concept of One Health approach, starting and to collaborate or to coordinate with people who you are best working at, that's researchers, and then they're moving up the ladder, and to know where you need to emphasize on, and then to present with examples to the government. And that is probably the best way to convince the policymakers, and with real evidence. And then the transitionary approach of the different sectors, which was very nicely highlighted by giving examples. I'd like to thank you both for the presentations. And then our group, very smooth group exercise for 5-10 minutes. I think what we showed was after the whole day, we more or less had the same approach to answering most of these questions, which I think gives us in a good light, because we have some consensus now that the name and the approach of this strategic network should continue in the way we have been thinking. And I'd like to thank the organizers, IPH, and all the rest of the people who have been planning this event for the strategic network. And I, on behalf of my co-chair, Professor Shai, we would like to thank you all for this day, and we invite you back this evening. I think at 6:30 we have the 6 o'clock. 6. We have the inauguration of the colloquium, and we will be back again at 6. Thank you very much.